Bismillah ar-Rahman ar-Rahim. Thank you for having me and جزاك الله خير أبو خالد الله يجبر بخاطرك ما أظنك تعلمت مني حاجة but we're here going to give you a small talk, share some insights about healthcare systems, and we're going to zoom out from the genetics in the morning to drug monitoring to biologics and therapy to healthcare systems and pathways. So it's like a bird's eye view of what happens in clinical practice in reality. So we're going to speak about integrated care models and specifically about integrated care models for patients with inflammatory bowel disease. We're going to share some of the literature and insights on how people approach systems of care. After that, Dr. Abdulaziz is going to take you about the Saudi Health Council as an overview, the healthcare transformation and how it should affect patients in general and how we can utilize that change to the benefit of our patients. And where are the gaps and where can we work together to improve the care of our patients? So integrated care specifically talks about bringing the system of care, whether it be diagnostics, therapeutics, follow-ups, and monitoring, from a fragmented system to a patient-centered system. So instead of the patient going around looking for an appointment for a radiology appointment after 1 year for an MRE, which we have in our institution, and then they run out of the medication and say, come back in 2 weeks and hopefully you're going to get your adalimumab. This system is designed to be flawless. It rotates around the patient and gives better outcomes. And why choose IBD for such a model? Our patients are young. They have a chronic disease. They have complications down the road. The current touch points with the healthcare system usually happen when crises happen. So when you have an inflammatory attack, hospitalization for surgery, complications, and it shouldn't be that way. So you're working mostly on stopping out fires in crisis mode. And if you had a better lubricated system, it would be a more smooth journey for both the healthcare provider and the patient. And in the intervention, usually it does not involve a single healthcare provider. So patients usually interact with dietitians, psychiatrists, surgeons, nurse care practitioners, pharmacists. All of those are fragmented, siloed systems, and the whole idea of integrated care is having that system rotate around the patient. There are a number of models, names, designations for these models. Some people call them IBD programs, centers, medical homes, which is an interesting concept that Miguel brought to the literature and we're going to talk about, and centers of excellence. Some of these are blurred and not pretty clear what they really mean, and there's no standard definition of how these work. They do come with a cost. The cost is time, setting up these systems, effort and commitment, as well as organizational change and culture change. All of these do come with a cost and are barriers. And maybe even focusing down your practice, so instead of seeing a lot of patients, you really focus on IBD specifically. And I don't think we lack that in our healthcare system. We already have people who are specialized in IBD, and that's their passion. But what does this commitment bring? It brings in better patient outcomes, better patient satisfaction, research opportunities, lowering indirect costs, and definitely there are going to be upfront costs to set up the system, but down the road it's going to pay off as an investment. So if you are going to embark on such a journey and try to get a pathway done, you usually have to have an alignment of the stakeholders that are involved. You have to sit down with your pharmacist, your institutional leaders, say, okay, we're going to need such resources. You're going to have a look at the risk assessment. If you take on too many patients, too little patients, are you going to open a fellowship program? You're going to have a certain number of flow. All of these things need planning. Then mapping that plan with a timeline, with endpoints, with milestones, and securing the commitment, whether it be financially or politically within the institution or on a macro level, as we're going to see on a cluster level, or even on a healthcare level across healthcare sectors, which we're going to see in the second half of the talk. And then even rolling out that program needs iterations and tweaking. So just initiating a program, you're going to have to keep on monitoring and changing according to the system you have and the outcomes. And hopefully that would succeed. Definitely there are barriers. The first thing, when you talk to the government, it's going to be funding. So money is an issue, and it's an issue everywhere. And I think healthcare systems do have a strain with funding. Human capital, and although you might think of, okay, we've got enough physicians, even if you claim you do have enough physicians, you have other allied healthcare professionals that need to be trained and accommodated to that sphere of IBD specifically. Experience. I think these meetings carry some of that experience and wisdom from abroad, locally, and sharing experiences within our healthcare system and what works and what doesn't. And I'm sure maybe the digital transformation contributes to the decreased lifespan of physicians with all that documentation that needs to be done, but it's here to stay. And I think we can capitalize on that and have better outcomes, and we measure what we're doing exactly. And also the current century's oil is data, and they really need to capture that data. And I think there was an initiative, I think last week, with the Unified Electronic Health Record in Saudi Arabia. It was launched, and hopefully that would be a good source of data of really what we're doing with our patients and what's happening. So Miguel had this concept. It's been in the ecosystem for a while now, since 2016. And you can see, as Sarah mentioned in the beginning of the talk in the morning, the patient is in the center of the house. And I enjoy the concept that the surgeon is outside. So he's never let in until he's needed. Keep him away. These concepts are interesting. Really, there's a lot of interaction, and it's more of an environment that grows with time, and people find their right places with different positions and roles and responsibilities. And Miguel did a really good job in describing those roles and responsibilities and job descriptions, and with specific loads, ratios, responsibilities. Hopefully when these turn into a complete program, you have a better outcome. Another issue that we've been struggling with, all of us, either on an institutional level or on a government level, whether it be private or public system, some of these medications are held back till they fail a medication or two. And you can say, okay, I want to start this patient on such a medication, and the pharmacist says, well, you're going to have to go through this line of medication first. Some of our institutions are more liberal, others are more restrictive, and these are, I think, based on BNT committees and how their medications are dispensed. Also, this may be more prominent in the private sector and achieving these medications to our patients. And then that's what's called step therapy, and there's a lot of literature around it, mostly in the US and Europe. It causes access cost, although it's supposed to be cost saving, but in the long term it might cause more costs, and suffering for patients and resentment of patients on how they're treated when they need these medications. It's not unique to IBD, and I think rheumatology and other chronic conditions do have it, and we can learn from these aspects and emulate it. So this is an intro to the second part of the talk, is how we can fix this. We talked about individual physician management of patients with IBD. Next, we'd like to look at it from an institutional level and policy and strategy level. And Dr. Abdelaziz is going to take us about how to optimize these care pathways, how to institutionalize it, disseminate it, keep KPIs and monitor it, and hopefully maybe even start registries on a government level, looking at different healthcare sectors and have a more accurate measurement of what's happening in the healthcare system. So with that, I'll just give the mic to Dr. Abdelaziz.